So I'm going to reflect back on the evolution of contemporary ECG interpretation standards, and I'm going to walk through some of the literature that I'm aware of and sort of give you my perspective on how we reached where we are today in 2017. I have no financial disclosures, but I do want to acknowledge that I work with some volunteer organizations also committed to the prevention of sudden death in the young. So for the next 15 or 20 minutes, these are my objectives. I want to review the development and progression of ECG interpretation standards in athletes, examine the statistical performance and accuracy of different ECG interpretation guidelines, and outline the impact of contemporary standards on the cardiovascular care of athletes. This study was done and published in 1985 in the New England Journal of Medicine, and I first learned about this study as a fourth-year medical student at UCLA. And I was fortunate enough that Dr. Jim Puffer, who's the second author, was giving a lecture on the athletic heart syndrome. And this was really my first exposure to athlete's heart and sudden cardiac death, stimulated a lot of interest on my part. But even back in 1985, in this article that looked at ECG findings and rhythm disturbances in athletes versus the general population, found differences between the two. And I drew that line there, sort of looking at some of our arrhythmias through MOBITS 1, which still holds true today. In 1992, Dr. Oakley published a study looking at the electrocardiogram in highly trained athletes, and this was one of the quotes in that study. Athletes with normal hearts may show electrocardiogram changes that mimic those of heart disease. The distinction between adaptive hypertrophy and pathologic hypertrophy may be difficult based solely on the electrocardiogram, and I think that still holds true today. In 1998, Dr. Corrado from Italy published a very important study on screening for hypertrophic cardiomyopathy in young athletes. And in this table, he published the ECG criteria that he used to look for HCM. This study was actually the basis of the 2005 European Society of Cardiology criteria that we'll review in just a second. And interestingly, even in 1998, the definition of an abnormal Q wave is actually where we're at now in 2017. But to think, over the last 20 years, just about every other criteria that was published then has changed. In 2000, Antonio Plicia, also from Italy, and several others published this paper. And interestingly, Antonio told me once that the way they came up with these criteria categories, distinctly abnormal, mildly abnormal, and normal ECG findings, was basically what they thought was going on. It was not evidence-driven. It wasn't based on heavy science. It was based somewhat on experience and a discussion around the table. In 2005, the European Society of Cardiology published recommendations for a common European protocol for screening and also their guidelines on ECG screening. In this study, still voltage criteria for LVH was still a finding to trigger an abnormality and further evaluation, and look at their QT interval cutoffs of 440 milliseconds in males and 460 milliseconds in females, another major change that's occurred over time. I had the fortunate opportunity to work on a theme issue that was published in BJSM on the prevention of sudden cardiac death in athletes, and asked Dr. Corrado to publish a paper and write a review article on interpretation of the 12-lead ECG. And interestingly, this just preceded sort of a prelude to what came the following year in the 2010 ESC guidelines. But even in this paper, they had moved isolated QRS voltage criteria for LVH over to the normal category. And in this paper also talked about earlier polarization findings that seemed unique to the healthy black or African athlete. I think we're all familiar with the 2010 European Society of Cardiology recommendations. A lot of credit goes to this group for really creating two categories when we look at an ECG. Common and training-related ECG findings, those that we think are really physiologic adaptations to regular exercise, and then the uncommon training-unrelated ECG changes that might suggest underlying pathology. This was really, I think, the birth of what we would consider modern or contemporary ECG standards in athletes. And in this paper, they talked a lot about not looking at voltage, but looking at non-voltage criteria for left ventricular hypertrophy. Colleagues from Stanford followed that pretty quickly with yet another set of guidelines that changed the way we look at Q waves, perhaps, and also extended the QT interval cutoffs. Joe Merrick, who's here today, who I've learned a ton from, in 2011 also published his findings on ECG in a group of high school-aged individuals and his interpretation criteria. This was at a time at the University of Washington where our group was really trying to formulate how we look at an ECG, and we realized that what we needed to do as sports medicine physicians is try to make it as pragmatic as possible and perhaps simplify it in table format where we really understood what we were looking for. And what this simple criteria tool did that we had photocopied and laminated and used in our examination rooms was list the abnormal criteria and also the definition of that abnormal criteria, so we understood exactly what we were going to look at on that ECG that might flag it as abnormal. And then also listed on this sheet were the common or normal findings for an ECG, and some figures or pictorial representation of some of the patterns that, as sports medicine physicians, were perhaps less familiar to us. We tested that criteria tool looking at different disciplines and a set of ECGs that included both normal and abnormal findings. A lot of credit goes to Irv Ossoff, who drove this study. And regardless of what your experience was, regardless of your discipline, use of a standardized criteria tool improved the accuracy of interpretation across all disciplines. The accuracy to correctly label the ECG as either normal or abnormal. This led to the first summit on ECG interpretation in athletes that we were fortunate to host here in Seattle in February of 2012. And it just seemed that there were all these emerging guidelines, new science, a ton of experience and expertise, and we brought many of these individuals here to Seattle in 2012. This led to published criteria that became known as the Seattle criteria. And I think this is where modern ECG interpretation sort of penetrated the sports medicine community, where we were able to help train or teach the sports medicine community how to look at an ECG with some more accuracy. One of the goals of the summit and the Seattle criteria initially was that training and education, and some of the ECG training modules were heavily utilized around the world, over 14,000 hits from individuals from 117 countries. But not shortly, with no delay, shortly after the publication of the Seattle criteria came new science, driven largely by Sanjay and his colleagues, looking at some of the markers that we might consider as abnormal and whether or not they really were a good distinguisher for disease. And again, it just seemed like the science was moving very quickly. This was really an important study published in 2014 by Sanjay and his group that defined what they called the refined criteria. And what's critical here is the presentation of a yellow group or borderline findings, where in isolation one would be considered a normal finding and without other clinical markers of concern, but two or more seemed abnormal. And with that in mind, I think it's important to look at some of the details of this study because it reflects a lot on other points of our discussion this morning. In this study, they looked at 4,200 white athletes, about 1,200 black athletes, and 103 athletes that were later diagnosed with hypertrophic cardiomyopathy. And if you looked at different criteria sets for abnormal ECGs, the European Society of Cardiology 2010 guidelines, there was a 21% abnormal rate. For the Seattle criteria, 9.6 abnormal rate, and for the refined criteria, 6.6 abnormal rate. There were 3,200 athletes that underwent ECG and echo and history and physical and other workup, and then importantly, 15 of those athletes, or 0.47%, were found with potentially lethal or serious conditions associated with sudden cardiac death: hypertrophic cardiomyopathy, ventricular pre-excitation, or Wolff-Parkinson-White, long QT, Brugada, and anomalous coronary. 14 of those 15, or 93%, were identified by ECG, and only one of those individuals was identified by symptoms. And also importantly, lateral T-wave inversion had a positive predictive value of over 22% for the diagnosis of hypertrophic cardiomyopathy. So with emerging science, as all guidelines must do, you must reevaluate if what you have and are using is really as up-to-date as it needs to be. So we hosted another summit on ECG interpretation in athletes in 2015, again supported by a number of groups, including AMSSM, the NCAA, and FIFA. And as many of you know, those recommendations have been published now in 2017 in 3 different journals: the European Heart Journal, Journal of the American College of Cardiology, and the British Journal of Sports Medicine. And what I want to show you from the British Journal of Sports Medicine is that right below the title are listed the organizations that actually endorse this guideline, meaning that these ECG interpretation standards hopefully provide an international standard of care of how we look at an ECG. This is the international criteria for ECG interpretation in athletes. We're going to have several talks later that can really dive into different aspects of this. And the international recommendations did 2 major things in these documents. One is, of course, that we updated the ECG interpretation standards. But the other area that I think is equally important is that we provided a clear guide for the appropriate evaluation of ECG abnormalities. And I think that's really important. If you're going to use ECG to screen athletes, or use ECG as part of an investigation for perhaps symptoms or family history or another finding, and there's an ECG abnormality, I think you need to understand what is the appropriate evaluation of those ECG abnormalities. And we were able to provide a clear link, and again, we're gonna dive into that a little bit later. Of course, there remain some concerns about ECG interpretation standards, and these are very true and important for us to recognize. There is inter-observer variability in the accuracy, even among experienced physicians. We have decreased the false positive rate quite a bit, but it's still something that we need to decrease further if we can. And I think the single hardest area for us to recognize is actually identifying what is a normal ECG in a young athletic population. False negatives can also occur, something called the prevalence effect, where recognition of some of the abnormal ECG patterns is difficult because they show up infrequently. Reproducibility, another question. Do standardized criteria improve accuracy across different populations as well as different users and different clinicians? And then we need more research about the additional investigations. What is our response as a clinician when we see an abnormal ECG? Is that approach to an evaluation to an abnormal ECG standardized amongst different individuals? So a question for us to think about: does lowering the false positive rate for ECG screening in athletes compromise the ability to detect cardiovascular conditions associated with sudden cardiac death? In other words, does modifying the criteria come with a cost? Do we sacrifice sensitivity to improve specificity? Listed here are 5 independent studies that tested the Seattle criteria, looking exactly at this question. So this graph shows those 5 studies. In blue is the European Society of Cardiology guidelines, in red the Stanford guideline, green the Seattle, and in purple the revised. On the y-axis the false positive rate, and those different studies. And you can see in each of the studies the specificity or the specificity improved and the false positive rate declined. And all of the studies found pretty much the same thing in regards to sensitivity. No change in sensitivity. 100% sensitivity for conditions associated with sudden cardiac death. All 3 criteria identified 98% of athletes with established HCM, and all with 100% sensitivity for the detection of pathologic conditions. So in the end, the Seattle criteria was able to lower significantly the false positive rate without compromising sensitivity. There's been one published study already on the international criteria, and I know another one that is in the works and likely to be published in the British Journal of Sports Medicine in the coming months. This was done by Domenico Corrado and colleagues. Accuracy of ECG for the differential between HCM and athlete's heart, looking both at the 2010 European Society of Cardiology guidelines and the new international criteria from 2017. So the specificity improved from 87% to 96%, or a 9% improvement in specificity when going from the 2010 ESC guidelines to the international criteria, and a non-statistical and very small decrease in sensitivity for the detection of HCM. Put another way, the 2017 international criteria reduced the number of unnecessary investigations by 69%, from 1 in 8 athletes to 1 in 24 athletes. We published a study that was a multi-center investigation in college athletes with over 5,200 athletes who were screened with ECG. Listed before you are the ECG abnormalities, and this was using the Seattle criteria. And overall, we had, I believe, a 2.8% total abnormal rate in this population. But if we apply the international criteria to this data set, what happens? With updates to the criteria, it pretty much removes one of our main false positives, which was with the old Q-wave criteria. If we change to the new criteria and remove left axis deviation in isolation, these individuals would also not be considered abnormal. Left atrial enlargement or abnormality the same, and right ventricular hypertrophy that's been moved to sort of the green list as well. So overall, we went from 192 abnormalities, or in total, or 3.7%, to 82, or 1.6, a 57% reduction in false positives, moving from the Seattle criteria to the international criteria applied to a college athlete population. No loss of sensitivity, and another way to look at this, 1 in 6 abnormal ECGs would represent a disorder at risk for sudden cardiac death. So if you're going to do ECG screening, at least in the US, what would you expect? And before you are just the most recent 4 studies using contemporary ECG standards to screen a US population of athletes. David Price in a high school population, our study at the University of Washington, our college study across the NCA, and then Colin Fuller's study at the University of Nevada, Reno. And you can see a relatively low false positive rate, and then the number of pathologic conditions detected, and the relative contribution of that detection from history and physical or ECG. If we sum that up in almost 9,000 athletes, the prevalence of pathologic conditions when you screen with ECG is what we've already known through other studies and estimates for about 1 in 300 or 0.3%. The contribution of history and physical for detection of those conditions, only 15%. And in these studies, 100% of the conditions that were detected that were associated with sudden cardiac death had recognizable changes on an ECG. So I think, and we'll talk about this more in other forms, but I think it's become sort of abundantly clear that screening by history and physical alone is probably insufficient if our goal is the detection of disorders at risk for sudden cardiac death. And for all the reasons that history and physical exam were initiated and aimed at early detection, expert use of ECG to accomplish the same goal probably does it with greater effectiveness. But of course, that's not the whole story. We can't all just initiate ECG screening and do it like experts and do it like expert centers with the same quality. We need to understand what's needed there, and as Kim and Aaron both alluded to, perhaps who to screen based on risk. Very proud of the American Medical Society of Sports Medicine position statement on cardiovascular screening in athletes. This was a balanced panel of sports medicine physicians with really opposing views on how to screen individual athletes. And what emerged from this was a framework to help clinicians decide how should you screen your population of athletes. And importantly, understanding in your population individual or specific athlete risk, your assessment of benefit to harm, the likelihood of false positives causing unnecessary investigations, et cetera, versus the potential benefit of disease-specific management. What are your resources around you? What's your training in ECG interpretation? Do you have cardiology resources around you to help you with this, both interpretation and the investigation of abnormalities or management of disease detection? And then, of course, in some cases, requirements from certain leagues will drive exactly what we do. But that the same individual in the same population with different resources may choose appropriately to screen differently. I know we heard a little bit about incidence and risk, but I just want to summarize it through this graphic here. In gray is the 25-year Italian experience that was published in JAMA in 2006, which showed a decrease in the sudden death rate over a 25-year period where they included ECG. And in yellow there is the Minnesota experience, about a 1 in 200,000 risk. But if we apply other studies onto this graphic, what do we get? So if we look at college athlete risk, age 17 to 26, it's certainly higher. Male college athlete risk, higher than that. In the U.S. military, higher than that. If we look at black male college athletes, now we're getting significantly higher than a Minnesota high school athlete or the 1 in 200,000 traditional estimate. Male college basketball athletes even higher, and a black male college basketball athlete even higher. If we look at the relative risk here, the relative risk of a black male college athlete having sudden cardiac arrest or death is 7 times higher than a high school athlete. 12 times higher if you're just a male college basketball athlete, and for a black male college athlete, the relative risk is 19. A relative risk of 19 is huge. I mean, we change recommendations based on statistical relative risk of 1.3, or higher sometimes. And so a relative risk that is 7 or 12 or 19 or however you want to slice this is really considerably high and really makes us press pause to ask in these high-risk groups, are there better ways for injury prevention? I've had the fortunate opportunity to collaborate with the National Center for Catastrophic Sports Injury Research, where we're trying to just monitor cases of sudden cardiac death and arrest across the U.S. in competitive athletes of all ages. And finally, we're at a point where we can really analyze a 2-year prospective data set in the U.S. And so we have 117 cases where etiologies are established through autopsy or other medical records that we've been able to review. And in 56% of those cases, they had ECG detectable conditions. But if we break that down further, in white athletes, it was only 53%. But in black athletes, it was 62%. In black basketball athletes, it was 68%. And in a very small number of college basketball athletes, they had 100% ECG detectable conditions that we presume they died from because they were found on autopsy. For hypertrophic cardiomyopathy as the cause of sudden cardiac arrest or death in this group, white males only 10%, but for a black male, 30%, which was statistically significant. Male basketball, 23% died from hypertrophic cardiomyopathy, and in football, 25%. So in other words, ECG screening may be most effective in our highest risk groups with the larger proportion of cardiomyopathy and ECG detectable conditions. And again, this is, needs to be driven by additional research and study in the future, but looking at what we have today, this is a possibility. So to summarize, what is the impact of contemporary ECG interpretation standards? And again, somewhat on my perspective here. But the first thing that it really did is it improved our accuracy. It improved our accuracy with a lower false positive rate and no demonstrable change or compromise in the sensitivity or ability to detect the conditions that we care most about. I think the emergence of modern ECG standards has really changed the dialogue when we talk about primary prevention. It's basically upturned the rationale against ECG screening that has been based largely on high false positive rates and concern for unnecessary investigations and those downstream costs. It's allowed many of us to venture into ECG screening with a higher detection rate, where the majority of cardiovascular disorders that are linked to sudden cardiac death have recognizable ECG abnormalities. And then lastly, I think as we've changed the discussion, changed the dialogue, I think it's allowed us to focus on other things. We no longer have to sit there and strongly debate some of the incidence numbers, et cetera, strongly debate whether or not what you're going to get from history and physical versus what you're going to get from ECG. And I think without so much noise, it's allowed us to identify what else is needed. And certainly training is a big part of that. That to do ECG screening using these contemporary standards, it requires training, it requires education, it requires expertise, and it requires resources. And currently, for many locations, even for college athletes in the NCAA, there remains a very large infrastructure gap between clinicians responsible for the cardiovascular care of athletes who may not have experience or resources to use an ECG, and those centers with great experience and great resources. So thank you very much for your attention.